conducted by Nizamabad Orthopedic Surgeons Association. Thank you, sir, for coming to all the way to our place, sir. I take the privilege of inviting the dignitary onto the dais. First, the most dynamic personality, TOSA President, Dr. K.J. Reddy Garu. Please come on to the dais, sir. I request Bansilalu, Dr. Bansilalu to escort him, sir. Garu was expected today, but she has not yet reported. Please, we'll wait for Madam, sir. Next, Dr. C. Hariprasad Rao Garu, please come on to the dais. I request Secretary Dr. Ramna Gaud Garu, please come on to the dais. Today's CME organizing chairman, please.
Dr. J. Prakash, President of NOSA and Organizing Secretary of this event. Dr. Ramna Gaud, Secretary NOSA, and my dear friend Dr. Bhupat Reddy, MLC. My teachers, faculty members, seniors, juniors, who have come all the way to Nizamabad from different places. I, on behalf of Nizamabad Orthopedic Association, Surgeons Association, take pride to invite you all and extend a warm welcome to this first midterm CME. It gives me a great pleasure to say that we are honored to host first CME after TOSA is formed. We have selected today's topic, fractures around hip joint, as it is commonly seen and is a challenging subject to all of us. The faculty selected are well versed with these topics, and they are here to guide us with their expertise and to make things simple to us. As we are conducting this seminar for the first time, we have
as treasurer of OASIS, the South Indian Orthopedic Surgeons Association, has a recent member of TOSA in our PSTs. First time in the history of OASIS, the present PSTs are all Telugu speaking guys, and we take great pride in coming to this organization now. I thank Nizamabad Association and TOSA for inviting us. As a gesture, generally, we contribute a honorarium of rupees 10,000 for every CMEs that are being conducted in every academic activities throughout the 6 states. Next, as I told you, OASIS is majorly doing a lot of academic activities across the 6 states. Last year, we had a meeting in Kodaikanal. This year, we had an annual CME at Guntur. Many members from TOSA have also attended that. Next year, it's going to be at Goa. I look forward to all the members of TOSA in coming to it and gracing that occasion also. Recently, OASIS has also started what is called as a nails con or a trauma con, looking at what is being held at various states like Jaipur, Mumbai and others. So a trauma con is also included, and it is annually done usually in the month of July of every year. Last year it was done at Chennai, and again next year also Chennai is trying to host it.
In the morning, respected dignitaries on the dais, I think all the names have been mentioned, and all the dignitaries of the dais. Dr. Jairam Pingali was telling, he was here by 8 o'clock this morning. So enthusiastic, I think we should take him as an example. And I must appreciate Hariprasad and Jayaprakash, their team, the amount of effort they put in organizing the CME. I was telling this morning, doesn't look like a midterm CME, looks like a TOSA Khan. Probably Ravi Babu, I think you had to beat this to organize next TOSA Khan meeting. Thank you very much for your initiative. I think as we discussed, we want to move on to the districts and conduct CMEs in every district over a period of time. And it's a really privilege to be here sharing with you. And I think probably regarding TOSA, I think Sudhir is doing a great job regarding membership. Those who have not registered for membership, kindly register for TOSA. Dr. Sudhir has got the forms and the information, including PGs. PGs will be made as associate members. Once you complete your exam, you will be inducted as a full membership. So kindly, during the breaks, contact Dr. Sudhir Kumar and join as members. And 12th February in Gandhi Medical College, and the registration forms are already available over the counter. So kindly register yourself. We want to make a big success 2017 Tosakon on 10th, 11th and 12th February. The brochure is on, registration is on. It's going to be a big event.
State Orthopedic Surgeons Association. And that too, it is conducted in Nizamabad by the organizers Nizamabad Orthopedic Association. On this occasion, I like to thank Mr. K.J. Reddy Garu and Hari Prasad Garu and Siddhi Garu, Ramana Gaud and Hari Babu Sir and other dignitaries on the dais, and also my senior teachers, Jairam Pingle Garu, Ved Prakash Garu, I.V. Reddy Sir, and other senior colleagues, and my Nizamabad, my orthopedic surgeons. And I still remember when I was practicing here, many of the people knowing it, and especially people from Hyderabad and coming from different areas. I'm an orthopedic surgeon. I did practice here for 20 years. So recently, past 1 year, I am not practicing. Today, I am very pleased to be here with you on this first midterm CME that to be conducted in Islamabad. I am very happy today because the way back when we practiced here, our senior colleague Dr. Kaule Garu and her friend Hari Prasad and Dr. Satyanarayana, very few people were there here. So it was not able to conduct any academics here. So we used to go to the Twin Cities Orthopedics Association where the dignitaries there sitting, and along with Dr. Srinivas Rao, sir, he was my professor, and I.V. Reddy sir, also my teacher, and Ravi Babu sir also, he was my teacher when I was in a post-graduation. So really, I am really happy today to be here with you, and that too a first conference like this to be conducted in Nizamabad. I am very happy. And government is planning to have a trauma centers on the highways every 50 kilometers. Recently, one trauma center is started in Kamareddy and other area in Shadnagar. So 108 services are improved. So ultimately, our goal of orthopedics for the media and the junior colleagues here to improve the quality of the life of those who are injured. So of course, fractures of the upper femur is always a complicated one, always subject to be discussed. So it is a very nice to have you having this great occasion here. And I congratulate the organizers, Dr. Jay Prakash, Dr. Hari Prasad and Ramana Gaud and Nizamabad Orthopedic Association once again. Thank you one and all.
Dignitaries on the dais for the lightning ceremony of this today's CME, sir. I request Dr. Sir to give a big applause for our first CME of Thank you, sir.
co-chairman, my senior professors, and the colleagues, senior and both junior colleagues. I welcome you all for this first TOSA call, which is a CME, which is midterm CME. So at the outset, I want to thank the Nizamabad Orthopedic Association for calling me for this giving the lecture here. Thank you once again. So we'll start off. Let the ball set rolling. Now the topic is the intercapsular fracture neck of the femur in children. Now the overview, everyone knows about this rare fracture. Till about 30 years, I must have seen about 10 to 12 cases of IC fracture in the neck of femur. Still, it's called an unsolved fracture. But in children, it has less complications compared to adults. It still can be treated. The bones, as you know, the stronger, periosteum is thick and relatively stable. And it's a challenge to manage this fracture because of the lots of complications like avian, non-union, so on. But many part, there is a subtle difference between these, the treatment for adults and the children. Open it. That's also they'll be.
Next one, sir. And my call.
Start one. This next one. So this is comfortable here. Right. As the pathogenesis, as you all know, the 10 minutes is not enough to cover everything. Just brush off all these things. It's the severe trauma followed by my height. Then the physis, which is a weak point. The precarious blood supply. All this will have an effect where the fractures are common children. Another part, I'm not going into detail. Everyone knows about this. Then the blood supply also is very important as regards treatment of this. I want to skip off. Everyone knows about this blood supply, which is commonly seen. Only part we are supposed to know is the soft spot kind of it. Soft spot which is there, you can see at the superior part where you can make out where the trochanteric notch is there, vessels are at the base of that which supplies the head and neck. This is till the adult, it keeps on changing. It's a precarious supply. I don't go to detail. Everyone knows about this. Now the mechanism of violence is the axial loading, the torsion, the abduction or direct blow. Cause of high energy trauma, all this can be there. But we commonly say, these in the kite flying days where lots of students come, fall by height, where the kite flying things. Only generally come across so many things. I must have seen about 2 to 3 at least during these kite flying days. This is a fall from height or the wide abduction or axial loading, all the common cause. Now the clinical feature, as you know, it's common to both the adults and the children where limb is shortened, the axial rotated. Sometimes with incomplete fracture, the patient can't have any fissures at all. Now the radiographs have been taken AP and lateral view, where the across the table lateral view is better than the frog leg view. Sometimes ultrasound or MRI CT can be advised to make out the stress fractures or pathological subcutaneous. Or sometimes minimal indentation, about 2 inches if we have incision from trochanter to lower down, open it completely. Now the landmarks here are, we always try to look at the reflected fibers of the gluteus maximus, where if you start a ream there, you can directly enter the neck, center of the neck. So always it's a landmark where the reflected fibers of gluteus maximus at the posterior nasra. If you start a reaming from there, take a guide wire, that right in the center of the neck. This is the landmark and always side plate. Now treatment part, we all summarize, that's what I've told already now. Now the complication part, as you have, is avian maximum, you get premature closure of the epiphysis, non-union, coxa condylosis, femoral stable impingement, limb leg inequality, and broken implants if retained for a long time. Now the avascular necrosis, different types we have, type 1, type 2, type 3. Then we have the how to prevent is this. Similarly, what have a treatment, with birth like treatment can be given. Or above 9 years, vascularized fibular graft can be done for the case of avian. Now the premature physeal closure, same thing. Some treatment, now the injury to the physis can produce maximum 2.5 centimeters of shortening. Does not matter at all. You can still do whatever you want. That should be there. Sir. The non-union can be done by what the Dr. Jairam is fond of doing it. Sorry, sir.
Hello.
Right.
Your time is up,
Right,
sir.
sir.
It's already
Okay,
over.
right. Okay, sir. Now the coxa is the what treatment is the basal, the correct osteotomy. The pitfalls, never introduce the pin in the center of the neck. Now never into the cortical subtracant, which is very avoid stress areas. All these can be there. Now the pearls, proper reduction is important here. Reduction is not adequate, there is loss of friction fraction. The displacement will be there. Now screws should be parallel, inverted fraction also. 1 or 2 gets into the posterior side. All things will be there. The body have incidents, you can make out and see. This I am going through. These are things we have done in the space. Right, please.
Pediatric hip fractures. Now I request my classmate and friend, Dr. Hari Sharma, to deliver his lecture in intracapsular fracture neck of femur.
Though I have been given the topic to discuss about the closed reduction internal fixation, open reduction internal fixation, there is another talk by Dr. Ved Prakash about more details and technicalities. So I will be mostly talking about the controversies in the intracapsular fracture management. It was Kellogg Speed who said it is an unsolved fracture. Basically because of the fracture being based in synovial fluid, being intracapsular, and that this bone lacks periosteal layer, and that there is eccentric loading. All factors make it more prone for complications. Next point is basically I am going to talk about the management in the young adults. Who are young adults? Those who are less than 50 years for all practical purposes, and those between 50 and 70 who have high activity levels, no medical comorbidities and good bone quality, and they have good cognitive status. These are physiologically young. So the management is more or less same in these two groups. What is important about it? These people have high functional demands and they require preservation of the anatomy and mechanics of the natural hip. In the incidence, basically we have two groups, one young 20 to 40 year group which usually sustains injury in a road traffic accident. Fracture is usually a vertical bowels type 3 type, and the next group is the larger number who have got injury due to the small falls. The well-known classification by Gordon basically has 4 types, and we all know that the inter and intra-rater reliability of this particular classification is not very good. It does not consider posterior cortical comminution, which is an important point in the prognosis. Usually it will be more useful in the elderly. Grossly, we can divide it into 2 groups. The undisplaced, that is the type 1 and 2, and the displaced type 3 and 4. And we all know about the Powell's angle, which basically explains the fracture line in relation to the horizontal. Anything more than 50 is considered as Powell's 3, and the shearing forces are more in this, complicating the fracture union. So the challenges are basically that there is an abnormal, or you should say eccentric biomechanics, and the vascularity is vulnerable in this area. Both of these lead to increased incidence of non-union and avascular necrosis. So the key factors are in the management, under our control are the accuracy of reduction and implant choice and position. And what are not under our control are the bone quality and the posterior comminution, the Jewett plates. About the technique of these surgical details, somebody else is going to discuss. So suffice it to say that 3 screws in paracortical places, inverted triangle, and 4th screw only for posterior comminution. Then there is no difference between cancellous screws or DHS for type 1 and type 2. And between DHS and DHS with derotation screw, again there is no difference for Gordon 1 and 2 fractures. Now dynamic hip screw is supposed to be with, particularly with derotational screw.
Kindly collect your memento here. One request to the speakers, kindly manage your time. Already we are running short of.
I hurry, please forgive me. This has been an unsolved fracture, as you know. Undisplaced valgus impacted fractures should be natural history is of 100% non-union. Femoral neck fractures in the elderly are associated with 20% of 1-year mortality. About 50% of the patients return to their previous level of work and function. Conservative treatment has got little role in this fracture. Only the moribund cases you can think of conservative treatment. Displaced fractures usually require reduction and fixation or replacement. This has been covered by Hari Sharma, older group, low energy trauma, younger group, high energy trauma. You have got this anatomical classification of subcapital, transcervical, and basicervical. Subcapitals are dangerous and usually go in avascular necrosis. Transcervical are divided into three. This has been covered by Harishama, which is the, and here is the line of incision. This is gluteus maximus, and this is tensor fascia lata in front. And then this is the capsule exposed. You have cut the reflected head, and here is the capsule opened, and you can use this inverted T fraction manner and use a joystick of K-wires or a Schanz pin. Smith-Peterson's approach is for more heavy patients, and it is from the anterior superior spine. The incision goes towards the lateral side, lateral patellar line. The length sometimes have got to be increased in obese patients. DHS plating for basicervical, and this is one of the examples where hemiopteroplasty for a failed neck of femur with avascular necrosis after the internal fixation. Pearls and pitfalls. Imaging. Recognize the pattern of injury through X-ray. Traction and rotation AP view is necessary. Negative X-ray but high degree of suspicion, you can order MRI. Polytrauma cases, CT is advised. Position of the fracture. Torso should lean to the opposite side of the operated leg so that the pelvis is stable and not rotated or tilted. Patient draped wide from ribs to the knee for complete access, just in case the small approach will not help. Okay. The reduction, the pearls or pitfalls are gentle traction and internal rotation to reduce fracture. Guide pins, threaded Schanz pins used as joysticks to help reduce fracture in open reduction. Good muscle relaxation is necessary for anesthetists, and anatomic reduction is necessary. If reduction is not perfect, open reduction. Avoid making hole below the lesser trochanter. Screws should be positioned against the femoral neck cortex. High angle Powell's 3 fracture, additional horizontal screw or sliding hip screw or cephalomedullary nail. Tip affect distance should not be more than 2 centimeters.
I've shown actually some papers,
Right.
one particularly by Upadhyay, and where he has done open reduction and close reduction. It is a prospective trial, and they did
How many
not-
cases?
They have done, if I remember correctly,
But
some 92.
decent size.
Pardon?
Reasonable number.
It's a reasonable number.
Yeah, okay.
Reasonable number. But overall, as you said, as of now, there is no proper double-blind control trial, randomized, about any of the controversies that have come in the discussion about the intracapsular fracture to actually conclusively say that this is good or this is not good.
But that's a good point because we struggle quite a bit in close reduction and do more harm
Yes.
than any good. So if there is no difference, instead of struggling too hard, maybe go for open reduction and do a proper job. As you rightly said,
It's like this. The anatomical reduction is more important.
yeah,
A not acceptable reduction achieved by close reduction and an acceptable reduction by open reduction, if you compare them,
Sure.
open reduction will definitely do better.
Yeah.
We are comparing where the reduction has been anatomical and is acceptable.
What are the prognostic factors? If you take MRI scan, dynamic MRI, how can you take dynamic MRI? Actually, it is possible in India.
No.
Whether you are following in Hyderabad.
No.
Okay.
Actually, I have no experience with the dynamic MRI, and
Vijaya
I
Diagnostic is
they are doing. Okay, but we have not done for any case. That's basically from the literature which I've quoted that there are a few papers about that. which only gives information about the possible avascular necrosis, and we can explain the patient ahead that, okay, boss, you are going to get avascular necrosis.
Only one gentle manipulation at closed attempt, then you go for open reduction. I want to know from the seniors, how many people stick out this particular principle? One single attempt at closed reduction. I myself have tried twice, thrice also until I get reduction. To be honest, I never limited to one close attempt at closed.
But my assistants do not hesitate in doing open reduction. The moment we find that a gentle reduction and perfect position is not achieved. I think it is highly important, and if there is any doubt and comminution and difficult to get reduction, particularly Garden 4, we don't hesitate using biological methods to augment.
Many times when we give a lecture, we do a little bit more reading than what we do regularly. And the person who gives the lecture ends up learning the most. That way, actually what I am thinking now, retrospectively, even as you said, maybe, by God's grace now my orthopedic practice is almost like 29 years. I must have done open reduction in maybe half a dozen cases and not more. And that too when the close reduction was failing because the fracture was somewhat with a long spike for the medial fragment, which is impaling the capsule, and unless you cut the capsule, we are not able to reduce. Unless in those cases, most of the times we are successful with the open reduction. But having said that, I also think that we are probably not assessing our close reduction as critically as we should be. Probably we are accepting it, with a little bit of give and take. If you really, go to that criticality, probably we will probably doing more number of open reductions than what we are doing now.
This is true. This is very true. My instructions to my seniors now who are helping me with the trauma is to open without any, and to use a fibular graft or use a muscle pedicle, which they don't want to do because it consumes time. But for youngsters, I would say that either TFO or muscle pedicle grafting should not be forgotten in this.
Orthopedic surgeons in the periphery, what type of investigations you would ask them to do? And should you start treatment of osteoporosis right from the day of injury or surgery?
Vitamin D man, and now converting slowly to using teriparatide. The first few months after surgery, you can straight away start, give a loading dose of vitamin D before surgery for osteoporosis, and continue afterwards with the teriparatide and also bisphosphonates together.
Any investigation to be done by the young orthopedic surgeons in the periphery? They don't have access to BMD or DEXA scan like that. Can you rely to some extent on the Singh index or the calcaneal index, which we have been following for a few years?
I have been disappointed with the BMD. Even after doing teriparatide, the BMD seems to be staying where it is after 1 year, some cases. So we all differ as individuals. Medicine is not a perfect science. And if you don't have BMD, don't worry. Your eyes...
I request Dr. Rajay Garu to present memento to Anmala Satyanarayana Garu.
Was Dr. Hari Prasad, Dr. Jay Prakash, for having invited me today to speak on this subject. Management of intracapsular fractures, neck of femur, non-union. This is my technique. We come into this world through the brim of the pelvis and exit through the neck of the femur. The history is that McMurray described an osteotomy for ununited fractures of the femoral neck in 1936, formerly used by Haas in 1922, where the femur is placed medially beneath the femoral head following an oblique osteotomy. You see, you should never have the screws crossing the fracture site, and there is rotation at the fracture. And this, we've done the transfracture abduction osteotomy, which I will show you the technique as we go on. 6 weeks post-op. This is 7 months post-op. And this is 8 months post-op. and this is 20 years post-op. This is after again 7 years post-op. So all these cases, we have results were that we had a total number of 30, we've added another 5, and females were 12, 18 males. Age distribution maximum was in the 3rd decade, and non-union period, the minimum was 2 months and the maximum was 10 years, both of which I showed you, and the minimum follow-up was 2 years and up to 35 years now. Advantages of TFAO over muscle pedicle is that there is minimal soft tissue dissection, less operating time, the anterior and the posterior capsules are not touched, and the hip stiffness is avoided, because all these patients have good hip range. Advantages of our total hip, of course, is that the patient has his own femoral head and neck, and the cost-benefit ratio, longevity, and in young children, what else would you do? Non-union and AVN of the femoral head have nevertheless remained as one of the major complications following fracture neck of femur, which ranges from 10 to 20% in spite of modern modalities of management. In these cases, all consecutive cases, we achieved 100% union rate, near normal range of movements, and by this procedure the neck shaft angle is restored and union is achieved. This procedure requires a high degree of cooperation because of hip spica for 8 weeks. Careful preoperative assessment of the patient's psychological and socio-economic status is mandatory.
Atmosphere. Thank you once again for your team. Hari, I think he's busy signing his certificates. I think we request everyone to stay in the hall and also kindly switch off or make your mobiles in vibration or silent mode. Thank you. Thank you very much. I think that's a good publication. I think it's an example for everyone to do original study and have publications. Very, very important. No point in doing so many surgeries without publication. It's only publication that take you long way. We ready? I think they're changing the laptop. So I'm going to discuss about hemiarthroplasty in fresh fractures, fracture neck of femur, intracapsular fractures, which is very common. I'm sure most of you have done many. I'm going to talk a little bit about the controversies on controversies, especially in hemiarthroplasty, because so much of literature on it. Okay. The whole idea is to improve the outcome, minimize the complications, try to achieve the pre-injury level in a cost-effective way, low morbidity, and reduce the incidence of reoperation with long survival of the prosthesis.
Fracture neck of femur, the definition varies, but I've gone back a few decades and included Maya's definition, which is anything presenting 30 days and beyond, any fracture of neck of femur presenting 30 days and beyond. So the longer you wait, the radiological changes start appearing, and you can see on the right, the neck has resolved, and slowly the proximal femur starts to migrate up, neck of femur fracture. So as we've heard, young patients, I think it's not fair for you to do either hemiarthroplasty or THR unless you've given reconstruction a thought or even attempted it. And we've heard such a nice lecture by Dr. Pingle on how to do these, how to operate on these patients and what techniques to use. Older patient, I think either of these two procedures may work. Hemiarthroplasty, if done well, and I'm going to touch a little bit about what kind of implants we should be using. Of course, as I said before, local conditions kind of determine what technique you use. I think your training is paramount when you decide to do a THR, but hemi seems to be done by many people, particularly in our country. And there are different procedures. You can see on the right is a traditional Austin Moore, although in India I don't see roughened stems, but they may be available. but osteomos are designed to be used in an uncemented fashion. I think the Thompson's people have used cement as well, but I often see osteomos being cemented, and that too very badly. So I think we need to be very careful about how we use prosthesis, what prosthesis to use, and what cementation techniques to use. So this is the kind of thing that I see very often here. It's a smooth stem and usually put in an uncemented fashion. So it's a non-modular bipolar, which doesn't restore any of the biomechanical aspects of a hip replacement. This is what Dr. KJ has been talking about, and I think this should be your standard, whether it's a locally made modular implant or something that, from abroad. So in countries like India, Africa, I'm sure you see many more presentations which are late. It starts off with a non-union, later on migration of the proximal fragment, loss of offset and other biomechanics. And then the more difficult aspect when you come to technical aspects is release of all the capsular and other soft tissue contractures. And if you leave long enough, you may see avian, although I'm quite surprised to see many neglected neck of femur fractures which do not seem to show an AVN. It's usually the neck that resolves. So I'm not going to touch on that. You've seen some wonderful pictures from Dr. Bingley. The over 60s, and don't take this number as a magic number. You can have, you can do arthroplasty in younger people, providing that their indication is correct. And with the current implants, with ceramic implants, with better polyethylenes, I think you can expect many decades of good service from these implants. So between these two, I think there are several studies that have looked at the outcomes of both, and almost all of them report that THA's total hip arthroplasty is better than hemi in terms of function. There is a slightly higher dislocation rate, but in terms of function, the THR is better.
You can always increase it if you want. So you take 3/4 of an inch, go in, and then you turn it in. You hold the top pins when you're abducting, and it closes. Main thing is the patients, you have to explain to them about the hip spica, in my cases. But now Satish has done almost 5 or 6 cases, and he's using an abduction brace. And I'm going to move to that also. Because I showed you about one patient from the Saudi where we did it. He went in, he walked out of the hospital on the hip spica. They're, so he went home and he had it cut off. And he just had the pins holding him, and he was walking about, and Krishna Reddy or somebody met him in one of the supermarkets after 5 months. I said, "Hey, you're the fellow." So they said, they took him to the hospital and took an X-ray, and that X-ray is 5 months post-op, which is united. So it'll heal. I'm sure now you don't need it. That would be a contraindication. The patient didn't want to lie down for six weeks or whatever it is in hip spica. But otherwise, I don't think there's you saw some of the horrible cases, 10 years non-union, united.
Comments and some questions. And first of all, I congratulate you for the out-of-box thinking and how to go about sticking to your technique. The only problem is in the adults, where hip spica, like you said, the Arabs or some Sarpira, will not accept that. So I want you to improve your fixation. Maybe a null spin or something else which will be more stable inside and doesn't pull out.
Not an external fixation as in external fixation. Yes. Because that you don't want a pin coming out of the skin. So externally and
No, external fixator without a plaster.
Oh, yeah, that's what. Brace. You're using a brace. Non-weight bearing, use a brace. And
brace you can use, or you can use a pin also. Why not? If there is a space in an adult.
No, but
not,
then you...
Not in children. They are too small.
I'm against putting a pin outside, coming out and locking it on the outer side. Because we're now putting stainless steel 18 gauge wire around the figure of 8. That has stopped opening up the osteoid. Only 2 cases.
Well, but elderly, can you think of some internal device which will give stability so that you can avoid spica.
Yeah, well, we have to, the only thing is you have to devise it in such a way that you don't put too much metal inside the head. There's hardly any space for that. You need just pins there. You can't put a big implant or anything. So you got to have the locking type of screws probably and close it and put it into a locking plate.
Correct. I think there are devices available if you explore the market. There's a proximal femoral plate also with locking screws with multiple holes. So you could consider using that and a double angle plate.
The problem is that when you put the first two screws in, the plate will be in there and it'll obstruct my other work. But we have to think of something. Because it'll have to be put in afterwards or something like that.
Can I just? I think Uday, you excellent talk. I think message should be very clear. Still the gold standard is hemiorthoplasty for fracture neck of femur. And please do cemented hemiorthoplasty. And use a cemented stem. Do not cement Austin Moore or similar, which is uncemented device, and it should be in a museum most of the time. So use a cemented stem with bipolar. If you want to uncemented stem, that's a different matter altogether. Though the literature, as Uday said, the functional outcome may be better with the THR. But most of the surgeons do bipolar cemented hemiorthoplasty, which is still a gold standard for displaced fracture neck of femur in elderly population. Uday, anything to add?
No, I agree. I think if you haven't got the background, that's one thing. That's the most important thing. And you just cannot go to a center, observe a few surgeries and do it. Total hips has to be, you have to restore the biomechanics. Dislocation rate is higher even in the best of hands because they do not restore the biomechanics. Because you've got this soft tissues are lax and the repair is not good. So if you do an anterolateral approach or a posterior approach, it doesn't matter. I always prefer the posterior approach because the lurch is less and in my hands, I do that better than an anterolateral approach. But the dislocation rate need not be higher if you follow the basic principles. So, your question?
How would you describe this fracture? It's a 33-year-old and a 5-day-old injury.
A 33-year-old such a kind of a fracture, and I just want to know the history of injury.
History of fall, yeah.
Yeah. But to me, it looks like some pathological fracture.
Okay.
Maybe some disorder I should suspect. And because I want to evaluate further with a lateral view first.
No, I don't have any more views. This is the only view you have to do with it.
I want to see blood profile in this particular case,
yeah.
Especially calcium phosphorus, alkaline phosphatase and PTH.
He's normal, take it. I think it is just the digital X-ray which was manipulated a bit to get that view. But then he's absolutely normal. He's just a young adult who had a fall. So what do you think you will do with him? What would be your plan? Would you offer surgery to him or would you treat him non-operatively?
Firstly, I offer surgery to him and I will go ahead with fixation with screws.
Cannulated screws. Anyone differs, sir, with the plan? Anyone would offer him non-operative treatment?
Everything has been already said. Only thing is I will warn the attendants as well as the patient that the chance of avascular necrosis and non-union are going to be high. It is always better to educate the patient because there is a certain chance of these two complications happening in spite of our all good work. And as far as the screw position, he has already commented. Nothing more than that. I think it is reasonably acceptable except that positioning of the screws is a bit.
As Jairam sir has said, because of being valgus impacted, then there is a narrow channel through which you put the screws.
And use the blunt end of your thick hair wire, blunt end, not the sharp end, because some of these, this is a 38-year-old, but in fairly old people that thing goes into. So use that to push and pull your fragment into place. If that fails, then you do a mini open Watson-Jones just above and then...
Muscular male. And any of you with experience doing the Watson-Jones and the problems you face doing Watson-Jones approach for these fracture neck of femurs, because it's not something that you would do regularly. So, because the abductor has to be released a bit from the trochanteric area in order to get a proper exposure, in order to get the proper exposure of the neck of the femur.
Probably you can.
All the speakers, and I will be very thankful if finishes before the time. Now I request Dr. Ram Kumar talk on management of stable intertrochanteric.
Because this is a very common fracture and everybody coming out of the medical school will well acquainted with procedure and having been known every procedure and every trip and tricks, everything. So is a base starting point of any orthopedic surgeon. So, but in this my presentation I will try to refresh few ideas which may be refreshing your thinking. So intertrochanteric area is that where you will see the between the trochanters. Okay. My objective of my talk will be to understand the variables influencing the patient and fracture, how to optimize the outcome, and review the principles of the treatment and suggest a few surgical tips to avoid the problems. So IT fractures is a major public health crisis. Almost 150 per 1 lakh patients of above 50 years of age. It requires blood transfusions. The comorbidities which will be augmented, which increases and the length of stay will be usually around 5 days, and non-weight bearing will be a long time. Important is, even when surgery is successful, there is 4 to 12% of fixation failures are there. So where we have to do much better. The predictors of the patient outcome were a pre-injury physical and cognitive status, presence of home companions, where operative planning and execution, post-operative ambulation and post-operative complications, in which the first two are the uncontrolled one, the other are under surgical control. So in the exposure, two things, there are muscle splitting and muscle lift. Muscle lift is accepted, and muscle splitting where the problem is there is a nervous denervation of the posterior fiber suckers. So muscle splitting is not accepted. We have to lift the muscle upwards. The one bleeder which comes is a branch from the anastomonic branches that should be ligated. The guide pin insertion should be center and the level should be just at the level of the lesser trochanter. So we have to achieve a neck shaft axis of more than 130. A minimally invasive plate fixation, a 2-hole DHS or percutaneous plating, they are there, but they are not much advantageous. The proximal fixation, 1 or 2 screws. So no difference in fixing sliding screws of collapse, no difference in the rigidity or stability. So the clinical significance, nothing. So there is some papers are there where X is also there for a moribund patients where X can be fixed like this. The X indications are 65 years old walking with osteoporosis. Conclusions is we have to remember the variables, uncontrolled fractures and surgeon controlled fractures. We have to plan for the uncontrolled fractures and we have to execute the surgeon controlled fractures exactly. The conclusion is implants have different rates to choose widely, but position of the screw centrally and very deep, that is the most important factor which decides the result. Prior decision, healing is no longer success, deformity and function matter, perioperative insult counts.
Trochanteric fractures and augmentation techniques. I am just going to discuss mainly on unstable fractures, its definition and treatment options, how nail is better, and augmentation techniques which are how they are useful in giving the stability to the fracture. So, sorry. As all of us know, this is a very common fracture. In day-to-day practice, you see these fractures very regularly than any other thing. But management differs from young to elderly, and whereas the reasons in elderly it could be because of osteoporosis, and in young people it is because of high energy trauma and usually associated with other injuries. And goals in young are completely different from goals in elderly people. Restoration of anatomy and to avoid the deformity during recovery, and improve union rates, optimal functional outcome, and preservation of the bone stock at the same time, and early mobilization, of course, it's same for both. Whereas in elderly, it is the mobilization which is more important, to make them sit, make them stand as early as possible, to get them out of the bed as early as possible after the surgery, and to restore them to pre-injury status, and of course fracture healing, and with a minimal surgical morbidity, because most of them have significant comorbidities in that age group. And non-weight bearing is almost practically not possible in cases of elderly people, because most of them, even if you advise them non-weight bearing or partial weight bearing, they tend to have ultimately land up in putting weight onto that particular limb, and implant should sustain these loads during this partial weight bearing period. And so the practical classification of trochanteric fractures is this one, that is stable fracture, which is towards left side, and do you have a pointer? And unstable fracture towards right side. I will show you what exactly is stability. The ability of the reduced fracture to support the physiological load is known as stability, and when internally fixed osseous fragments of these fractures are not able to share the weight bearing loads, and that is known as, so that's how it looks after the fixation. This is a cut section of the head. You can see the bone implant interface which is impacted and has got a less cutout rates. So I'll just rush through. Augmentation is a technique wherein you inject a cement through these holes, pores in the spiral blade, by which you improve the bone implant interface. So that is the injection device. Through the same system you inject a bone cement. You can see these particular pictures, cement being injected. So that's where the cement is getting dissipated, and that's how it looks after the fixation. So to conclude, I'll just go. So these are the few examples, and so goal of surgery is to bear weight as soon as possible in post-operative period, especially in elderly. PFN has got biomechanical advantage, and elderly invariably bear full weight. So you should have improved bone implant interface that can be achieved by spiral blade as well as augmentation techniques using cement through the spiral blade. Thank you.
Thank you, Dr. Srinivas.
Then introduction, cephalomedullary nails are commonly indicated in paratrochanteric and subtrochanteric fractures. There are 4 intertrochanteric fractures which are called unstable fractures. One is the reverse oblique fractures, transtrochanteric fractures, and fractures with large posteromedial fragment with loss of calcar buttress, and IT fractures with subtrochanteric extension. These nails used in the trochanteric region are classified as piriform portal nails. They are straight in the epinail, and trochanteric portal nails, they are angulated 4 to 6 degrees according to their manufacturers. And surgical procedures, it starts with preoperative planning. The mandatory are the X-rays. We'll take X-ray pelvis with both hips to know the neck shaft angle and medullary canal diameter, and to plan for whether the nailable or plate. And the affected hip is in lateral view, and we know the anteroposterior displacement and also bowing of the femur. And traction views are indicated if necessary. Patient is having more combination, and we'll go for the traction views. Rarely patient with 4 or more number of fragments. In younger people, it may need CT scan. The instrumentation are the following, and also positioning. Patient is positioned in supine position on a fracture table with the affected limb is in adducted to 10 to 15 degrees and the chest is adducted to 10 to 15 degrees, and keeping the unaffected limb on the abduction and flexion or only adduction with extension. And reduction, during reduction, very gentle traction and followed by tying the foot end of the plate, then followed by internal rotation. If there is any excess of traction, it can lead to overhanging of the pelvis to the same side. It may cause difficulty during the making a portal to the entry and portal and causing varus angulation and leads to failure of the surgery. And for the draping, we will extend the sterile field up to the and above up to the iliac crest region and 3 stitches with nylon sutures. This is to prevent towel clips. They are coming in between the lateral views. They will cause difficulty in viewing the pictures in lateral views. And multiple folds of towels should be avoided at the site of nail entry. This may cause drifting of the nail towards the lateral aspect, causing the varus entry nails. And fluoroscopic images during the surgery, they are AP and lateral views and true lateral views. And the true lateral views and lateral view, in lateral view there is a overhanging of the posterior aspect of the greater trochanter will be seen. In true lateral view, the head, neck and also shaft of the femur, they are within the same line. The incision is planned according to a line drawing vertically from the anterior superior iliac spine down and along the shaft of the femur is the center. It approximately 2 to 3 finger breadth above the greater trochanter will make a 3 centimeter incision and cut the gluteal fascia and split the gluteus medius muscle. And the entry portals, they are making the entry portals, there are various devices. One is the 2.5 mm 2.5 mm K-wire, 2.5 mm guide pin. Another is there are various companies, they are manufacturing fossa finders with steam and pin 4 mm. And also
good afternoon. I'd like to invite Dr. Srikanth Gollamodi.
Now, I don't need to talk too much about the classification, it's already been talked. So, what do we do in A1? DHS by far, several level 1 studies show that that's the best implant. Now, this study from Norwegian registry shows clearly the superiority of the DHS over the IM nails. I mean, I'm deliberately using the word IM nail because PFN is a trademarked for a particular company. So proximal femoral nails fare very poorly with reoperation rates significantly higher than the DHS in this particular series of more than 7,600 fractures, of which 1,300 were nailed. And they showed quite significant complications with the IM nail. For the A2, I think this article has already been shown by one of the previous speakers from the US. It's an RCT, randomized control, again level 1 study, which shows that the sliding hip screw is far better even in A2. Now, other studies like Bandari et al., if you see the meta-analysis of the first decade of this century, there have been significantly poor results with IM nails. That's probably because of the older generation gamma nails. If you see the meta-analysis of any IM nail literature, it's predominated by the gamma nail, which is made by Stryker. Unfortunately, is not available in India. But they had significant problems, the first and second generation, so the DHS always fared better. So most meta-analysis in the first decade of this century showed that the DHS is far superior to the nails, whereas this particular meta-analysis from Bandari from Toronto showed that IM nails were as good as the DHS, not superior. And hence their suggestion is to use the DHS wherever possible up to A2. Fractures that you will have to make a decision on, and you do these PFNs, and then like that, and then you can see this is the immediate post-op, and you see cortex to cortex continuity, although in the lateral view it looks as if it's overlapping, and then it collapses, controlled collapse with no progression in the screws, the so-called Z or the reverse Z effect with healing. This X-ray is stability, and so the two screws are diverging in one plane, and then that is after healing you can see that the lesser trochanter has been completely ignored and is still staying where it was at the time of trauma. Now, the Cochrane, this is the latest Cochrane meta-analysis, which shows again there is absolutely superiority of the DHS versus the nails. And this Cochrane meta-analysis involves all types of nails, all different companies. But again, there is a slight preponderance in functional outcome which seems to favor the nails, but not borne out with fracture complications or successful healing of the fractures. Now, so finally, what do you want to do? The DHS, what is it good for? All A1s and A2s. And the only study that I know so far which has studied what fractures do well at the DHS is measuring the lateral wall thickness, which has problems again because of projectional issues. But they feel, these authors feel that 20.5 millimeters is the optimum thickness for DHS to work very well. If you don't have the thickness, you can alternatively use the bottom screw. Seems not collapsed. I was expecting it to have a Z effect because the fracture is collapsing, and controlled collapse. Now this is another interesting case where you see the immediate post-op and you happy. 7 weeks, the center bottom screw is going forward into the joint. This is the Z effect. This scares you because it can penetrate the joint. But luckily, again, 12 weeks, it stayed that way. The fracture had stabilized and healed. Sometimes you may have to go in and take that screw out if you think it's going to perforate the joint. The Z and the reverse Z. The reverse Z is where the screw comes out of the nail completely. I have not seen that. But one important thing is this fracture. If you misread the fracture and you misdo the nailing or DHS technique, you have terrific price to pay. The patient does. The surgeon, this is a very stable A2 fracture with a fracture of the lesser trochanter, probably A2-3. So you could have gone for a DHS. You would have probably got good fracture interposition and compression. Surgeon chose to do this, and the tip apex distance and the reduction is terrible. So both ways it's poorly done. So there's no surprise there. And regarding the screw versus helical blade, well, this randomized controlled trial from Switzerland shows there's absolutely no difference. The helical blade is superior in rotational stability compared to the screw, but it's got very poor pull-out strength. So it catastrophically, if it fails catastrophically. So in summary, DHS is safe, A1, A2, but in A3 you have to do a meticulous reduction bone to bone and use a trochanteric buttress plate. IM nails, yes, example PFN, very useful in A3 if you are not comfortable doing a very difficult DHS, but still needs meticulous technique and reduction.
Speakers to come to the dais, Dr. Ramkumar Reddy, Dr. Srinivas Kasha.
For inviting us for this wonderful program. So I'll talk about management of implant failure and non-union in treatment of intertrochanteric fractures. Fixation of intertrochanteric fractures is highly successful, as we all know. All of us have very good exposure to this fracture, and all of us have very good ability to fix these fractures. We have our own preferences, and like what Srikanth said just now, I myself am a young person and I prefer nails, contrary to what Srikanth has said. Yeah, and there is a very low failure rate. There is some failure rate, but the failure rate is pretty low. The causes of failure of fixation are, number one is inadequate bone. Inadequate bone, is there something we can do about it? We have to think about it, ways to devise, ways to find out if the bone is adequate or not to hold the fixation. Second is improper implant, that is in our hands. Third one is inadequate fixation. Inadequate fixation in our circumstances is sometimes not completely in our hands because the kind of instrumentations that we have with the constraints that we need to work in doing our jobs, sometimes you find that the instrumentation is inadequate, which causes problems. And implant failures, even the best of the best, the Synthes and all the imported implants, they also fail. They also break. And infection is the other one. If we see the quality of the bone, there are a couple of studies. What they've tried to do is they've tried to do the BMD of the bone on the opposite side. When you have a fracture on one side, they try to measure the BMD on the opposite side and see when do these implants fail. And they found that when the BMD is less than 250 milligrams per centimeter, there is a high risk of fixation failure of surgically fixed pertrochanteric fractures. Now, tip apex distance, which we all know is so popular in DHS, but what they have found is even in PFNs, the tip apex distance holds good, and you need to make sure that you maintain that tip apex distance even for the PFNs. It's a bit difficult to find out what to do when you're using 2 screws, but when you're using 1 screw, definitely this thing as DHS holds good.
Thank you, Sunil Absangi. Excellent lecture delivery about management of implant failure and non-union in
At the outset, I would like to thank the organizers for giving me this opportunity to participate in this excellent academic program. My topic, role of primary hemiarthroplasty and THR in IT fractures. I must say at the outset, the role is not very great. But there is a definite set of people who will get benefited with arthroplasty as a primary procedure in cases of intertrochanteric fractures. We know intertrochanteric fractures, they take place in the part of the bone which is very cancellous and highly vascular. That's why majority of the time can be managed successfully with internal fixation, achieving osteosynthesis. That's why the need for arthroplasty is not very great. Here, the mainly mechanical problem. If you can restore mechanical stability to the fractured bone, it is going to be successfully united. But there are situations where your mechanical fixation devices might not be able to hold the fragments in position, in which case probably arthroplasty will definitely come in. Key steps further, offset inversion, very important. Reduced trochanter will guide the vertical seating of the process. In bipolar, if you are doing for an intertrochanteric fracture, bipolar or THR, you don't have any local anatomy, everything is disturbed. Then how to judge the insertion depth of the process? This is easily can be arrived at by reducing the fracture. As soon as you open the fracture area, reduce the fracture and measure the distance from the tip of the trochanter, fractured trochanter, to the intact proximal end of the distal fragment, that is the shaft fragment. Keep that distance in mind. It may be 2 centimeters or 15 millimeters or whatever. This will help you in seating the process towards the insertion. And axis of the leg will guide you the version. Because local anatomy is not there, you have to go for indirect techniques of arriving at these points. Stem fixation, cement stems are chosen, very rarely uncemented, because most of these people will have osteoporosis. It's always better to go for cemented stems. Cementing technique, as I said earlier in the discussion part, I always choose manual insertion because these elderly people are having cardiopulmonary problems many a times, comorbidities. If you go blindly for second generation, third generation insertion of the cement, you might produce complications, pulmonary complications. But that's why I always go for manual cementing. The cement will be in a doughy state. The monomer is not there. Already it is polymerized. So a very little monomer. The question of you having these hypotensive episodes, I have not seen so far. That's why I never think of pressurization in this.
An overall summation of what we've heard about proximal femoral fractures so far, I think it will be many conclusion slides going together. So, what are the kind of factors which are not under control? The quality of bone, patient compliance and comorbidities. And what is it that we can do? Use an appropriate fixation device depending on our choice and expertise, recognizing problem fracture patterns, the stable and the unstable fractures, performing accurate reductions, and achieving an ideal placement of the implant. So what are the complications in these fragility fractures? Non-unions, avian of the femoral head, implant cutouts, ZFX, implant breakage, detachment of the implant, and intraoperative and late post-operative peri-implant fractures. So once we identify these complications, and then we talk about how to prevent these things. Reduction and fixation of femoral fractures, I think we had a bit of a discussion about this in the morning, but any displaced fracture, a grossly displaced fracture in the population we are talking about, I think we should start thinking in terms of arthroplasty. Then we could think of a hemi or a total hip replacement. But the reduction is the most important factor in femoral neck fractures. Now the entry point, it should be accurate. It should be at the tip of the trochanter with a medial bias is what I would say. You should be going medial to the tip of the trochanter. And the distal tip of the end guide pin, if you see, is in the dead center. It should not be skirting the medial cortex. If you're skirting the medial cortex and the entry point is lateral, as you start to push the nail, because it's a soft bone, the nail will create an oval entry point, and the nail will get displaced laterally. There is a chance of you breaking the lateral wall and getting a malalignment when you're pushing these nails in. So entry point is very important. And like I also already mentioned before, nails in this scenario cannot achieve reduction, unlike in diaphyseal fractures. We need to achieve reduction. If necessary, make a small incision. There is no harm in making a small incision. Applying these clamps minimally invasively, you will not evacuate all the fracture hematoma which is supposed to be preserved. So achieve reduction and then start the procedure. Without achieving reduction, do not start a proximal femoral nail or when you're doing a DHS, normally you're opening it anyway. So use your hands to seat the nail. Always you should be able to put the nail in with your bare hands. The hammer should be used only for final seating, adjusting the nail position by a millimeter or two. If you are having to bang your nail in with a mallet, there's something wrong. Review your procedure. You should not be banging these nails in. Even the long femoral nails, what I tend to do is start off with the nail facing, the tip facing the lateral cortex, and then slide it in, then push it back into the normal position, and then you push it in all the way with your bare hands. I don't use a hammer to bang these nails.
Thank you very much, sir.
Good afternoon, everybody. At the outset, I thank organizers for giving me the opportunity, and also I thank all our members for their active participation and cooperation during the IVOCON 204 at Hyderabad, which has been conducted by our state body with successful results. And you know that I am contesting as President-elect for IOA this year also, since I lost last year with narrow margin. I seek the cooperation of all the members for my candidature, and also please tell all your colleagues also. And ballot papers are trickling in, so you can post ballot paper, or otherwise online voting starts on 20th of this month, and for that you have to register before 20th. If it is not
Delegates went for the lunch, and as per the request of our president, so we want to go for the lunch for half an hour, sir. So we'll cut down our lunch time by half an hour. We'll come back. We'll start with the panel discussion for the antibiotic prophylaxis and management of infection in proximal femoral fractures. Dr. Satish Reddy garu, Dr. Srikanth Gollamudi garu, Dr. Hari Sharma garu. Sir, please come on to the dais, sir. And Dr. Srinivas Kasha.
The whole idea is to have a consensus of opinion of the experts on the panel as well as from the audience. What our practice is, and is it really evidence-based, or are we going to change based on the evidence? I think the dictum in the medicine is you have to practice evidence-based medicine. It could be your own evidence or somebody's evidence. I think the days have gone where it works very well in my boss' hand, it works very well in my hands. Probably that's good for you, but it has to work in everybody's hand, and that should be evidence-based. As far as antibiotics concerned, can we have the? I think we orthopedic surgeons, I think we use two medicines, antibiotics and analgesics. We survive with only two. So we should be good with these two medicines.
You don't need to extend beyond what you said.
Absolutely, I think you raised a very good point. The commonest cause, the most common cause is soft tissue handling. If we do not respect soft tissues, no amount of antibiotics will prevent your infection. That's a very good point Ivy Reddy made. Okay.
So leave the living tissue which can fight on its own. You
Yes.
don't need to give any antibiotics.
Absolutely right.
Only
Absolutely.
situation will be where the patient is immunocompromised, probably.
Sure. That's a special
Because
situation.
Patient cannot fight himself.
Yeah.
Because immunity is deficient. In which
Sure.
case, probably you are justified in extending. Otherwise, there is no need, no indication.
Satish, anything to add?
No, I've been using 48 hours and stop for last 14 years.
Very good, very good. Hari Sharma.
Till the drain is removed, I usually give injectable antibiotics.
So how long you put the drain
Usually
in?
I keep the drain for 48 hours.
48 hours, okay. So you do not generally use antibiotics longer than 48 hours?
For most of
Good, that's one step ahead, very good.
And most importantly, the antibiotic that you use, it has to be a gram-positive coverage.
Sure.
We don't want third generation cephalosporins used in orthopedics.
Sure.
And try to keep it simple, either cefuroxime or
based on your
amoxicillin, clavulanic
environment
acid.
And your microbiologist, whatever.
Exactly.
Yes, okay.
Yeah.
So 24 hours, but I think whatever reason, you should not be continued for more than 48 hours.
Clot at the wound, making it impermeable to
Sure.
outside in infection within 24 hours. That is the reason why everybody goes for 3 doses, 1 pre-op and 2. As the rest of the panel, especially Sunil, has emphasized, the antibiotic chosen should be a broad spectrum and one of those antibiotics that can be used for prophylaxis. People tend to use antibiotics which are reserved for resistant infections as a prophylactic, which is worse.
Antibiotic which used for prophylaxis should not be used for infection treatment. If any infection is the same, is maybe the same, but antibiotic should be reserved for prophylaxis. And in case you develop infection and the organism is sensitive to the antibiotic which you routinely use for prophylaxis, that should not be used. So you should have one group of antibiotic for the prophylaxis, the other one for the infection treatment. Yes, you go on, you want to take a mic? No, if you discharge within 24 hours, yes. No, we should not continue. That's the whole idea. No, both are same, oral IV. If oral antibiotics are strong enough for absorption, there's no need for IV antibiotics. So it would be the same. Should not use for more than 48 hours.